Great. Well, I will go ahead and get us started. Thank you all so much for joining. My name is Erica Mobley. I am Vice President of Administration at the Leapfrog Group, and I am thrilled to have this esteemed group here to present on lessons learned over the past year through the pandemic. And we've got a terrific discussion on tap. Just want to go through some quick housekeeping items. So you'll have the opportunity today to hear from Fred Guterl, our moderator, as well as three esteemed panelists, Dr. Michael Bell from the CDC, Devin Jopp from APIC, the Association for Professionals in Infection Control, and Jackie Blanchard from Healthcare Corporation of America, HCA. We are going to welcome questions from the audience. So to ask a question, you can type it into the Q&A box you'll see at the bottom of the screen, or you can also raise your hand if you would like to ask your question out loud. If we're able, we'll get to as many questions as we possibly can. And if you're able to, if we're able to answer your question, you'll be asked with a little pop-up box to unmute yourself in order to ask it. And finally, right before we get started, I want to call attention to the Best Infection Prevention Products 2021 list that was published by Newsweek yesterday. The panel today is not endorsing or recommending any of these products. Many of them were used successfully over the past year in the fight against COVID-19. So if you have not already, encourage everyone to take a look at that website and the list of products after today's webinar. So with that, I will stop sharing and turn it over to Fred to get things started.
Okay, thank you, Erica. And hello, everybody. We're here today under the auspices of Newsweek and Leapfrog, and we're going to talk about infection prevention and control. We've got I'm really excited about our distinguished panelists who are very experienced in their field and represent a very interesting different points of view. So I want to start by going around the horn just to talk a little bit about the early days of COVID and the way the healthcare system was grappling with preventing infections and preventing the spread of infection, and then we'll go around again and we'll talk about how you guys rose to the challenge and what lessons you've learned. But I just want to start by reading something I found in a paper in the scientific literature. This comes from JAMA, Journal of American Medical Association. As investigators documented how, this is talking about the early days of COVID, when the disease took people by surprise. Investigators documented how a single suspected case of SARS-CoV-2 led to 6 major clusters involving 5 hospital wards and an outside nursing home and dialysis unit, with infection ultimately confirmed among 80 staff members and 39 patients, 15 of whom died, which is kind of startling. And overall, the rate of infection, of hospital acquired infections of COVID-19 is estimated between 12 and 15%, at least according to one literature review that I found. So I want to just talk a little bit about these early days and what happened from your points of view. What led to this? How did you guys cope with this surprise? Really, this kind of surprise outbreak. And I want to start with Jackie, who is kind of has her fingers in the day-to-day operations of a number of hospitals at HCA Healthcare.
Yeah, thanks so much, Fred. And I really appreciate that, starting off with the early days. I think the first email I received was There's this case of pneumonia of unknown etiology that may be travel related, and it looks like it's coming from Wuhan. So I remember distinctly getting that email and just alerting us as to what does this look like? How does it impact us? Is this something that we need to worry about? So those were the initial conversations before the virus even was named. And what I can tell you, the first thing from an infection preventionist point of view that we always look at is to just identify how strong our program is. And starting with the foundations of all infection prevention practices and making sure that we have all the components that we need, that we have a communication trail, that we have a way, if we need to get communication out quickly, that we have a way to be able to do that. We also needed to leverage leadership to help them understand what this might be, what to look out for, and also, identifying what the needs might be, whether that is, as I mentioned, a communication need, a resource need, a people need, or a community outreach need. So those are the things that we started to identify early on as we learned as a society, as a nation, and as a globe, exactly how this virus was behaving. We all learned together. And I think this is the first thing that really leveraged us as a community. And so many departments got together to truly understand what this virus can do, how it was behaving, and how it was affecting people.
Excellent. Yeah. Good. So, Devin, what are you your people in at APIC are the professionals who deal with this kind of thing. So what were you hearing from people in the early days? I mean, what was life like? What were the challenges?
Yeah, really at the end of the day, I think when you look at what we do as infection preventionists, we deal all the time with trying to prevent and stop the spread of infections. And I think there's certainly through hospital-acquired infections, but even prior, right? We've had H1N1, and we had a number of other what I would call close misses. But I think the scale and the volume of this, and also the level of sense making that we had to try to make, because it was something new, it was novel. We were all trying to figure out what was happening in real time, and then trying to adjust for it. And so I think, early on, what I saw was a lot of improvisation and agility, if you will, of trying to say, hey, wait a minute, we know this is different. We know that we've got to look at, our established procedures and processes, and then try to figure out new ways that we can adapt to this virus. And so, there was certainly cases where we were trying things out. Some things didn't work, some things were. We certainly had guidance that continued to evolve and shift. And so the role of the IP was a crucial one, because it was really trying to help make sense of this within our organizations, and try to bring that guidance to life. And so I think that was one of the roles of an infection preventionist. And I think, from a real life perspective, and I'm sure Jackie could see this even closer than I, but, I think we had our IPs and our healthcare folks were heroes, really trying to do their best to be out there, trying to figure this out, being there for their colleagues, keeping our patients safe and our colleagues safe, and at the expense of, I think, even themselves at times in terms of burnout, and trying to help address this within their communities was really their role. So the IPs have certainly been on the tip of the spear in helping to figure this out within their organizations.
Just to stay with Jackie and Devin for 1 second, and I'll get to you, Mike, in a second. The shortage of personal protective equipment, PPE, was very acute at the beginning. How big a problem was it? How did you guys cope with that?
Well, I'll start.
Okay,
Jackie,
go ahead.
Follow in. I mean, it was certainly a huge problem. I think a lot of organizations across the board felt that we had adequate supplies, that we were ready, but we weren't ready for a pandemic. And I think, at the scale and the proportion, and then I think the other challenge, of course, was, even if we had stockpiles, some of it went very quickly, and some of it, like, for example, N95 masks were a very acute example of that. And so I think it was a real problem, not only at the beginning of COVID, but also continued to lag throughout the pandemic. I mean, nitrile gloves were in short supply. at different points in time, we kept seeing these shortages. And from our perspective, it was, not only kind of the facilities struggling with their own stockpiles, but then even finding a supply chain able to really fill those orders was a real challenge.
So Jackie, how did you guys cope with that? Did you cut up T-shirts to use them as masks, or did you have to improvise, or what did you do?
Yeah, you used the word acute, Fred, and I'm with Devin. It really was over time. It became chronic for us. We were very blessed to have such great partners in supply chain. We do have an internal supply chain program, and we do have global reach. Our partners have global reach, so we were able to source products quickly. But I think the real issue, and you bring up the T-shirts that people were wearing, was the miscommunication, and people, they react and behave based on fear. And so as as word got out that this virus has high transmissibility, that people started, people were dying, and it was just a few months. And then we have so many different forums of communication out there. People will go to their go-to media source, and they will react to that. And so we needed to also stay on top of the CDC recommendations, take that, use that as our leverage in terms of, hey, listen, we have to be really good stewards of the products that are short right now. With that, we will continue to keep you safe. All right, so that's how, we got all of the inventories of the products that we do have. To Devin's point, there were stockpiles and, in pockets throughout the organization. We leveraged that when we needed to, and we also partnered with other entities as needed. And so that's how we were able to get through it. It was just strong partnerships with other sources.
So, Mike, the CDC, Mike is with the CDC, so he has the 32,000 foot view. But the CDC guidance, in the beginning, I'm not an infection specialist, but I do remember in the beginning, the word was wash your hands, before it was widely understood that the virus was airborne. What do you recall about the CDC guidance in those early days? Were you guys were sort of learning on the fly? How did that affect the ability of hospitals to prevent infection? Did it help? Did it hurt? We can't hear you. You're muted.
Muted. How am I now? There we
Good.
go. Infection control practices are not magically designed for one disease, right? The things that we use for COVID are the things that we use to keep patients and our colleagues safe every single day. The difference here, just like with Ebola, is that with new infections, you can actually see when there's a failure. And that gets really scary. We don't see it when we spread an infection to a patient and they end up with an infection 6 weeks later. You don't trace it back to me, the doctor, doing something wrong, or a nurse cross-contaminating something, right? That gets lost in the mist. It's only with an emerging infection like COVID that is unusual and new, or something like Ebola that is highly lethal, that we start seeing the impact of infection control almost in real time. And so I think that is the source of the fear that Jackie brought up. People are suddenly confronted with the reality that, gosh, they have to do this perfectly for themselves, not just for their patients. And that is kind of where the rubber meets the road. In terms of how infections spread, we also know that respiratory infections in general have two major things. You either are splashed, or three major things. You either splashed by them, you breathe them in, or you touch something and then you rub your own eyes or nose, right? So we want to block all three. At the beginning, our guidance basically said, don't get too close to people, cover your cough, and keep your hands clean. Those are basic things that we say for any respiratory virus. And that's a good starting point. As we observe, part of what we're looking at is this something like SARS-1, where mostly people in the community weren't affected? It was only the few people who got sick that became more and more infectious and then ended up spreading it in intensive care units when they were super sick, right? This COVID was the opposite, much more like seasonal flu, where it's spreading like crazy in the community. And that is part of what impacts the health system. The big challenge that we saw, frankly, was that this was not localized as a single importation that stayed put because of that community factor. Once it was in the country, every health system, every community was at risk. It took a little while. Our big cities on the coast were hit first, but then you saw the second wave affect the middle part of the country in a terrible way. And so that, combined with what you said earlier with the supply chain challenges with international acquisitions, really created a major problem that continues on till today. We still have nurses and EMTs and ED docs struggling at points to get enough personal protective equipment of the right type. And so there are so many intricacies here that become very germane very quickly that we ordinarily have the luxury of not really thinking too much about. I think that was the big test of the system, the expansiveness of it, and the fact that we have the community side really driving this into healthcare in a way that didn't happen with SARS-1.
Interesting. So let's go back. Let's go now to a little bit more to what we learned from this ordeal. And Jackie, you when we were talking the other day, you used the word agility, which I thought was really interesting. A sort of concept for responding well to what was basically a situation that was where there was just a great deal of uncertainty, and everyone was sort of learning on the fly. Tell us what you mean by that, and how did that apply to what you guys were doing?
Yeah, thanks, Fred. I'd love to take credit for that. Actually, I think it was Devin who first brought it up, and I expanded on it. But it is a great word, and that's probably a lasting word that we were able to not even realize that we had as a healthcare group, as healthcare entities, and as healthcare workers. Just individuals. I don't think people really appreciated their own sense of flexibility until they got hit with the crisis this head on and at the scale that it did. And so with that said, everyone needed to know that when they came in the morning, they knew that the environment, the climate, the PPE, the guidance might change by the end of the day, and they needed to be aware of that. We learned when guidance went out, we learned to put, that term underneath, that this is the guidance as of today, and we would put the date on it so that people knew that if it changed the next day, they can't say, well, that's not what they told us last week, and the breakdowns in infection prevention, I think, Mike just said this so fluently, is, these were very basic foundational things in infection prevention. This is our native tongue. The hand hygiene, environment cleaning, the masking as part of any type of droplet transmission and airborne transmission. That is not new. That has always been an infection prevention practice. And of course, the social distancing was, kind of new to COVID-19 in terms of it becoming a foundational IP practice as part of this, as part of the pandemic. But the agility, again, even as infection preventionists, we really had to also have a lot of grace with that, to not lose patience when people ask us the same questions over and over and over again, and maybe say it in a different dialect, and when I say different dialect, I can say the same thing in a boardroom, but say it differently to a patient, all right? But it's the same message. So I think that's another incredible way that people really showed up, was their flexibility, their resiliency, and their agility in terms of COVID. And that's one thing that I wish we could bottle, because we need that all throughout healthcare.
So Devin, you did bring up the word agility before. So tell us what did that mean for your folks? And was this a stressful thing on healthcare, on infection control people? Was there a lot of burnout? Was there Tell us about it.
Yeah, boy, there's a lot in there, and I think it certainly was most stressful. And I think it played out in so many ways, because I think, as we mentioned earlier, with this whole agility, this whole idea of kind of experimentation also happens, right? And so when you're getting kind of the guidance and we're learning along the way, there's things that everything kind of has an action and an equal opposite action, right, at some level. And so, for example, when we talk about masking, well, multiple times you're hearing different things where it's like, okay, well, hey, now it's N95. Well, it may be different for the public versus for the hospital, right? And so now all of a sudden you get confusion between even some of your healthcare workers. So trying to make sure that messaging, to Jackie's point, communication was key. There's other areas where we thought in some cases like we may want to double gown, but then we actually found that then there was some issues with double gowning that we had to deal with, right? Where we have like the fungal infections possibly that we have to deal with. And so, when Jackie's talking about these pivots and changes, that's where we found is that we were trying our best to try to make sure that we were keeping our workers and our patients safe, but at the same time having those real lived experiences that, oh, wait a minute, maybe we have to change this up. Other things, for example, outside of the traditional acute care was like in long-term care. We started realizing actually how porous our systems were, where a lot of the long-term care or assisted living facilities have staff that go between the different organizations. And so they were carrying, in essence, COVID into these facilities. And so, we weren't, how was that, and there wasn't an IP infrastructure in those facilities, an adequate one, to really help prevent that from spreading. And we saw really terrible, tragic outcomes from that. So, those were really kind of some examples, and we could go on, but I think at the end of the day, it certainly was a challenge for our IPs. We did and have experienced a tremendous amount of burnout. I think that was already on top of an aging workforce and a shortage of challenges of getting IPs, which is something we're trying to work on here and spur more of, because I think the need is not going to go away for infection preventionists. But I think this whole idea of burnout is very real, and it wasn't just IPs; it was other providers and as well serving in their institutions and organizations. But a very real thing that we experienced.
Excellent. So, Michael, at the CDC, which is a big organization that, well, I don't know, I don't want to call it a bureaucracy, but it's a big organization. How did you guys, how did you respond to the changing circumstances of this pandemic? I mean, how was that a challenge for you?
With any outbreak, we are always looking for what's working and what's not. We are always starting with what makes the most sense based on what we know, because in addition to being a bureaucratic organization, we are actually full of doctors and scientists. And this is what we do every day. We're not mostly on camera having lovely conversations like this. And so our day jobs really are about knowing what's going on and what works. But that changes with a new strain, with a new insertion of a dangerous organism in the United States. We need to make sure that what we think works actually does. And if there's any indication that it doesn't, we need to make an update and inform our colleagues who are on the front lines. So that's what we do with any outbreak. This one's no different. It also is about understanding how we need to communicate, because our workforce in this country is not just highly trained IPs and nurses. They're not just clinicians who think about infectious diseases. There are very, very wide-ranging skill sets, ranging from EMTs to respiratory therapists to environmental hygiene specialists and facilities engineers, all of whom are at least as important as any of us clinicians to keeping our patients alive, right? And being able to communicate with them effectively is incredibly important. And so tempering messages, tailoring them, and delivering them to the right people is also part of what we do during any outbreak. I'll also say that we focus a great deal on the what you should be aiming to accomplish. We rely on our colleagues in the trenches to figure out the how, right? I can tell you that you should make sure that none of your staff are directly exposed to respiratory secretions. But you can do that either by separating them in different rooms, by doing telemedicine, but you can also do it by putting up barriers or different hallways for respiratory patients. And of course, you can use PPE when you have it. So all of those approaches can accomplish the what, but the how needs to be decided by the people actually doing the work. Otherwise, it doesn't work very well. Along with the what and the how is the critical issue of the why. And that's another area where CDC is extremely invested. What we find, to the points that Devin and Jackie made about agility, is that well-educated, well-informed staff members who understand the why are much better off when it comes to figuring out a good how, right? If you're not sure the why behind a recommendation, then you have to kind of treat it as almost a religious edict where you must follow the great rule and not ask questions. But that's exactly the wrong thing. We want people to ask questions. We want them to understand why we want them to do something. If you understand that the reason for wearing a respirator is so that you don't inhale something as opposed to just protecting your nose and mouth from a splash, then it becomes very intuitive that that respirator needs to stick to the edges of your face in order to keep you from breathing around the edges, right? If you're not thinking about what that respirator is supposed to do, then you're just told to wear this thing. And there you start to see people wearing it wrong, with their nose poking out, or with a big gap on the side, and that doesn't help anybody. So the why behind the what is also very important, and that's why CDC is investing so much right now through things like Project First Line that you might have heard of, to reach people where they are and give them that why behind the recommendations.
And Fred, maybe if I could weigh in behind Mike, at the end of the day, we really relied on the CDC's guidance and expertise through this. And I think, the agency doesn't get enough credit for the fact that, they were dealing with an extremely difficult, virus and trying to do their best really with all the different information they're learning and getting it out in our hands. And so, while I think agility cuts twice ways, and I would probably go back to the bureaucratic piece and say that, I think the CDC was pretty highly effective in terms of getting this guidance out and as it evolved, getting in our hands. And so just kind of sending that virtual fist bump over that way, because I think it was really the both and the how, what, when, where, why that Mike pointed out that made it work. So.
Well, that's virtual fist bumps are always good. But Michael, I did want to follow up on what you just said. It seemed to me, and again, I'm not from the vantage point of being among infection prevention and control specialists, but more among the lay population, the lay audience is mainly what I'm experienced in, and among the general population, and I include by that businesses and institutions who were following or CDC guidance or thought they were following CDC guidance, where there seemed to be a big emphasis on things like deep cleaning and cleaning surfaces and preventing infection from fomites rather than an underappreciation for the airborne nature of this, and also especially considering that the virus was aerosolized and could hang in a room. And even now, I mean, when you go inside a store or something, and you'll see signs that'll say, "Please keep 6 feet apart," which to me indicates a lack of appreciation for the notion of aerosols, that aerosols don't respect the 6 foot distance. And so is this, I mean, as you look back on this, is this a failure of the CDC to get the right message across, or does this require a rethinking in how the medical establishment in general thinks about infection?
Well, Fred, I think that your point about the wide range of people who need to use the information is a really good one. It is very different trying to communicate with the lay public than communicating with our own professional colleagues.
That is absolutely true. But
Yeah, no, definitely. But that said, there's also the reality that we're dealing with a fairly, how can I put it, different set of expectations. It's kind of like what Devin, Jackie, and I were talking about earlier with Amazon delivering overnight almost anything you can think of. We want it, and we want it right now. And we want it to be easy. And we don't want it to be inconvenient. And I hate to tell you that pandemics are inherently inconvenient. The reality here is that at the beginning, when there's something new, especially a respiratory virus, we don't take chances. We tell people you need to wear a respirator in the hospital. And we got tons of pushback for this, right? People are like, oh no, a mask should be fine. Look, people in Europe are just wearing a mask. They seem not to be dying. And yet we have to do what we think is right. Similarly, we know that respiratory viruses can live for hours or even days on surfaces, including COVID. If you run your fingers along a banister and then rub your eyes, I can tell you that there will be times when you will inoculate yourself with a virus and get yourself sick. So it would be really irresponsible not to include environmental hygiene and hand hygiene in the conversation. I want to make sure you get this because you've come back to it a couple of times saying that's wrong, it's all airborne, and that's not true. It's both, and that makes it harder. In terms of the 6-foot thing, I will tell you there's also this interesting relationship between distance and social distancing versus air handling. And so it's really not enough to talk about distance without talking about air quality as well. And what I mean by that is that if we are just breathing quietly and one of us is infectious in a room, right, being 6 feet apart isn't going to help the other person because over the course of 15, 20 minutes, the air mixes and you end up being exposed. But if you have really good air handling, the amount of exposure can be suppressed, right? And that's why we're talking about school air handling. That's why we're talking about hospital air handling and making sure that restaurants are well ventilated. That's why it's okay to get together outdoors because that's the ultimate air handling, right? In contrast, you can have the best air handling in the world, but if you're 2.5 feet from somebody and they sneeze in your face or cough at you or shout, then you're going to be exposed no matter how good the air handling is. Think about the last time you held up your favorite 3-year-old, right? And she coughed directly into your mouth. That is not an air handling solution. That is a distance solution. It's just that cute kids are hard to keep at 6 feet distance. So I think here it's again that why piece. It's an oversimplification that is understandable. We all want a quick soundbite and just easily encapsulate the message and move on. And we want it all to be clear at the beginning and not change. And in a perfect world, I would want that too. But the reality is, as we learn more things, for example, when we start to see that people sharing an exercise space in Europe ended up transmitting the infection in the air at a distance, we have to take that seriously. Up until then, we were seeing that airplanes and other sort of tourism-based things didn't seem to be showing us that this was very effective. And the reality is, it's not. It's a rare event, right? And so we take special care when we're doing aerosol generating procedures in a hospital because we expect it to be there. We are now being extra careful in enclosed spaces and things like aerobic studios that are poorly ventilated, not a good idea. We also learned that if you're doing choir practice, it only takes one person, and over the course of a 90-minute choir practice in a poorly ventilated space, a lot of people can get infected. At the same time, we know from lots of air travel that a potentially infectious person didn't transmit it to the entire plane. We learn from these things, we synthesize them, and then we try to package them in a practical way, right? So we are not telling everyone to go out in scuba gear. We are not telling people that they have to be locked down forever, but we are saying you don't want to be in an enclosed space with shared air for a long period of time with a lot of people. Don't do that. It's a silly idea, right? Once the entire country is well immunized and ready to deal with this in a healthy, safe way, we can probably start moving back to normal. But in the interim, there are a lot of unknowns, and we will continue to sort of address those as they arise. Right now, it's the Delta variant. We're looking very carefully at what this means to both healthcare professionals and the community in terms of what we need to do, what we can still relax, and what it means for the trajectory of this infectious disease. Unfortunately, we're not done with the story yet. So it's a little bit early to summarize, but hopefully we're moving in the right direction.
Okay, well, let's hope. Hopefully, we are moving in the right direction. And speaking of the right direction, I don't know, Erica. I don't know if I'm not seeing questions from the audience here yet, and it could be that they're coming in and I don't see them. But I just want to remind people that if you have questions for our esteemed panelists, please, now's the time. So I've got plenty of questions that I'd like to ask, but you guys may or undoubtedly would have a different point of view. Okay, well, we've got one, and this is, I'll read it out loud, I guess. This is from, well, no, maybe this is from Frederick Hendrickson. And he wants to talk about the need for the public to be better educated on ventilation. So Frederick Hendrickson, I'll put you on live and you can ask the question directly. Okay, go ahead. You should be live. You're muted. Frederick Hendrickson. Paging Frederick Hendrickson. Hello?
Can you hear me now?
We can hear you, yes.
Sorry about that. I'm on a busy road. Apologies for the background noise. No, Dr. Bell, thank you for the overview regarding guiding the public. But I think as Fred was also alluding to, it seems like there's still a lot of misconception when it comes to better ventilation, that many still follow the very early guidelines that were published regarding the distance. Is the CDC doing some?
Boy, this is, we've lost.
Guidelines provided with the focus of better ventilation phase, that is being put out to the general public. I hope you could hear that.
Yeah, you know, I'm gonna put you. Yeah, you weren't coming through very clearly. So what I'm going to do is I'm going to read the question that you typed, and if you have anything you want to add to that question as I read it, type me a note. So what Frederick Hendrickson wrote is, I understand what Dr. Bell is saying regarding distance, but why does he continue to push back on guiding the general public to the airborne nature of the virus? It seems the public needs to be better educated on ventilation. Is that? I've got another comment here. Sorry about this. Well, Michael, would you respond to that, please?
Yeah, so I don't think we're pushing back on the inhalational nature of COVID. This is why we have been asking healthcare personnel to wear respirators from the very beginning. That hasn't changed. We are also very much focused on avoiding situations where that inhalation can occur. And that's what I mean by places like exercise studio and closed indoor spaces. So we are very clear about those things. Do we talk about the physiology of breathing and particle size? No, that's probably not an easy message to shape for the general public. But it is something that we focus a great deal on the occupational side. These things are also tempered by the how do you prevent inhaling something versus how can you reduce the likelihood of exposure in the first place. We prefer the latter in the sense that if everyone is wearing a simple mask, we reduce the amount of stuff that we breathe out. And that has a huge impact on the amount of inhalational potential within an airspace with a very high rate of success, even if it's not a perfect mask. And if we can get everyone to do that, especially early on before vaccines, that has a much better and more reliable impact than air handling alone. Air handling is great, don't get me wrong. I'm a firm believer in improving air handling. That said, there's also a missing piece here. With hospitals, I have clear standards of what constitutes sufficient air handling and how it should be maintained. We have hospitals that have, or hospitals do have, staff that are dedicated to do the engineering piece to make sure that that's functional. If you go to a strip mall or a restaurant or a gymnasium, there are no such standards, right? There's no bottom line against which we can make recommendations. We can just say, make sure it's as good as you can get it. And most of these places don't have full-time staff that are professionals at HVAC systems. And so that raises the question, okay, it's fine to talk about, but how do you implement this in a way that is doable and actually meaningful? And so I think we have a long ways to go in terms of our general public air quality issues. I think this is a great moment to try to make use of the really challenging year and a half that we've had and do the best we can with the lessons learned that came from that time. I think that if we do that, we can probably have a very good impact, not only on COVID, but also on seasonal flu and many other annual respiratory infections that we used to take for granted. Those of you who have been watching realize that there was really no flu season last year. There were almost no cases. Our children's hospitals report having had a complete absence, really, in many cases, of these routine respiratory infections, which is wonderful. So if we can do this generally and stop transmitting infections in public spaces, that could be a great benefit to society as a whole.
Okay, Michael, I think we've had you on the hot seat for long enough. Thank you. I think I'd like to, I got a question here about what looking forward, what has this pandemic taught us in terms of how to improve practices in this field? Let's start with Devin, since we've been sandwiching you in the middle here. Why don't we start with you?
Sure. No, I mean, I think there's kind of the what's next, and really it's kind of interesting because as Mike indicated in some of his comments, we're not done with this pandemic. And while we may be done with it, personally I'm ready for it to be over. And I think there's this unwinding process of, what do we have to do right now to make sure that we're still being safe, we're keeping our workers, our patients safe, and then what happens after we kind of emerge out of this, right? And I think that's kind of the what's next. What's going to dominate infection prevention is going to be a lot of that around what is that, how do we get back into whatever the new normal is going to look like? I think that's going to be an important part of our next, at least year, if not couple years ahead as we try to unwind this and look ahead, or wind some of these things up permanently, right? And I think that's where we assume that sometimes that we're going to go back to the way things were. I think there's kind of a new normal that's coming. The other part of this too is we also have to get back to some of the basics that are out there. During the COVID-19, we've seen increases in some of our HAI rates or healthcare-associated infection rates, going back to really trying to make sure that we get our capacity and our structures and processes aligned to be able to go back and help make sure that we're keeping our facilities and our patients safe, right? We don't want to save a patient from COVID and have them get an HAI. And so I think another what's next is going to be also kind of reimagining how do we strengthen our infection prevention efforts on an ongoing basis, not only in our hospitals, but our long-term care facilities, home health, out in our public health infrastructure. I think the IP is an important part of this, and even outside of healthcare. And I think we've obviously heard a lot about the transportation or entertainment industries, but across the board, infection prevention has to become really everyone's business, and we cannot let our lessons of this terrible tragedy wane. And so, there's all kinds of other exciting things on the horizon around technologies and genetics and other things we could talk about, but I think in the here and now, those are kind of some of the things that we're keeping an eye on and trying to make sure that there's a lot of blocking and tackling that has to happen here in the next couple of years.
Devin, if I could just follow up with you on that. Obviously, this pandemic hit long-term care facilities hard, and they were under the spotlight. When this is all over, when the pandemic is one day when it's all over, will long-term care facilities just sort of slip back into sloppy practices, or do you think that this pandemic has imbued them with a lasting appreciation for infection prevention?
I think it's like human nature is to slide back. And I think we as a society have to make sure it doesn't. And I was talking to an executive at an assisted living facility. He said, they used, when someone was bringing their loved ones in, their first question is, how good's your food? He goes, and now their question is how good are your infection prevention?
Yeah.
And I think that's the reality around long-term care, but I'm not sure everyone's going to go willingly. And so I think we're going to have to look at some smart legislation regulation to really help make sure that IP is embedded in their culture, that they have the infection prevention structures, the trainings in place. A lot of these facilities don't have full-time infection preventionists, and so I think those are going to be some of those hard-fought and one pieces that we're going to have to do. And I think the other part is also surveillance. Making sure that we build robust surveillance systems in these facilities, like we have in acute care, is going to be crucial. So, I'm an optimist, but I think it's going to require a little bit of a nudge and kind of a general, all of us working together to make sure we don't fall back.
Right, Jackie, you talked very eloquently the other day about technology and how you guys really had to leverage that. Is that going to be a technology, the lessons you learned from your use of technology in both, among your staff and telehealth and all that, is that going to have a lasting effect, do you think? Is that going to improve the way you guys work? And are there other things that you're taking away from this ordeal?
Oh, absolutely. I think that's going to be truly sustained. If any one of us knew to buy stock in Zoom a couple of years before, and if you remember too, travel was absolutely banned, right? And so when we have over 185 facilities in 21 states and people say, all right, Jackie, are we doing this correctly? Well, I can't hop on a plane the way I used to. And even then, there's time that needs to be taken into consideration. And so now being able to stand up a camera and going into, a hallway, going into a break room, and making sure that chairs are apart, there's enough equipment in there that's needed, how equipment is being cleaned. So much of that actually existed, but we just never appreciated and leveraged it to a point where we were forced to. And then people became affluent with using it. So now, we're using it every day, even though we're able to travel again. I think that we've developed a balance of when to use technology, and when, it makes more clinical sense to be there in person. I think also another, in addition to the technology, I know I want to call out something that Mike said earlier, which is, bring guidance in a practical manner. And during the pandemic, we are very clinically focused. I'm a registered nurse by background. I really needed to understand the limitation of my own clinical sense and allow operations to do their thing, because we cannot exist without the other. We are very codependent. The vent shortage, that was a huge operational issue, and that was an operations program in making sure that we were able to get that in and then and be able to get that leveraged quickly across our clinical departments. So partnering with operations and again, ensuring that our clinical guidance also has to be partnered with the execution of that guidance in a very practical manner. We cannot be inconveniencing our staff to be able to get to the right information. So, and the third thing, if I can just take just a few seconds, is the unintentional consequences. I just happened to go into when bleach was flying off the shelves. If you all remember, I looked actually in the poison control site, and you can see the bleach poisoning was a direct correlation. It just skyrocketed with the use of bleach. So we're looking to some of those things now. The double gloving, as Devin mentioned earlier, the double gowning, that all had actually higher risk of cross-contamination. So those are all the things that we needed to balance out in terms of the communication, not just, as Mike mentioned, being able to explain the why, but also the why behind why we don't do some of the things that people thought were safe, because they thought they were better protected by doing so.
Excellent. So Michael, so what are you guys taking away from this experience? What are the lessons you've learned that you hope will make the next pandemic give us the ability to manage it a little bit better? And what kinds of things would you like to see? What kinds of things would you like to see happen, either with legislation or regulation or whatever, or investment that would help us in the next time around?
So there isn't a single thing, but it's an array of things that are all about networks and sort of an integrated system. I think what we've learned is that there's a great deal of fragility built into the way we provide care. There's also a great deal of benefit and convenience, right? We don't want to lose that. Ambulatory surgery can be very, very helpful. Having skilled nursing facilities that people can go to and not remain in a hospital can also be very helpful. It can also be cost effective. At the same time, if we're moving patients to those locations, then we need to follow the patient with the same kind of support and safety that we provide in an acute care hospital. And right now, there's a lot of gappiness in the system. The question you asked of Devin, what about all these nursing homes? Well, they're supposed to be kind of comfortable residential places where you can safely age, but in fact, a lot of them are having to manage complex medical issues. And it's not okay to say that, well, just figure it out. I think we need to make those investments and decide how we can do those things correctly. The other piece of this is, sort of looking ahead. There are a couple of other pieces. One of them that's been on the to-do list for a very long time is thinking about the locations where we provide care. If you go into most hospitals in this day and age, they are designed kind of like, the colonial architecture of hospitals from the mid-1800s. They haven't changed that much. There's a lobby, there's a nursing station, there's a long hallway with bedrooms, there's a nightstand, right? We assume you need a nightstand, but do you really? Think about it. There's a drawer where people put stuff. Who cleans inside that drawer, right? Half the time it's dentures, the other half the time it's dirty underwear. And we wonder about transmission of resistant organisms. Those are not okay. And so I think there's a lot of redesign we can do. For the emergency department, the fact that right now we are stuck with a system where people are sitting together in a waiting area for hours. Some of them are infectious, others are bleeding, right? Is that really necessary? Or can we do a better job of sorting people, triaging them, and putting them where they need to be so that they're not cross-transmitting infection to each other or to our staff? There's that kind of built environment piece that also includes the ventilation question from a little while ago, where can we be doing a better job of creating a safe environment inside healthcare? And then lastly, I think that there's a great deal of learning and progress that can be made in the world of how do you teach people to understand what they need to know when they need to know it. I think that there's the traditional education system that we hope will prepare everyone as best possible to become nurses, doctors, IPs, and everything else. But in addition to that, there's always more information that needs to be delivered. How do we take somebody who doesn't have the luxury of spending an hour reviewing a PowerPoint slide or going to a conference? How do we give them a quick, a colleague of mine calls it snackable content. How do we give them a quick bite of information that they can carry with them, ideally on their phone, right? And use that to move our workforce in a good direction. I think those are all areas that complement the points that Devin and Jackie made from sort of the infrastructure / process side of the house, in addition to the clinical care and patient care side.
Excellent. Michael, you mentioned earlier in an earlier conversation we had about the need for investment in training for infection prevention, or someone mentioned it. I just want to throw it out to all three of you. I mean, do you think that we are under investing in that now, and what needs to happen?
I mean, I'm certainly happy to go first on that one, and I think wholeheartedly yes. I think when we look at infection prevention, particularly IPs, but really infection prevention, even outside as a field and a understanding, there has been a lack. And I think some of the work that Mike's team's doing on Project First Line is super exciting. It's kind of taking the work of infection prevention and saying it's not just IPs, it's everyone's, which I think is great. But there's so much more where we need investment as well. I think for years we've been cutting back on our public health infrastructure. I think we have to reinvest in this. We have to harden our systems and invest in infection prevention across the board. And I think whether that's doubling down in our organizations, looking at how our cultures are nurturing and supporting infection prevention, embracing that, all the way to making sure that it's actually in places where it just wasn't or wasn't adequate, like long-term care we've talked a lot about, but you could take that to other areas too, like home care, right? And I think, those are all spaces where we've got to go back, re-examine, and then put dollars where they make sense. In acute care facilities, there's a lot of the CMS is involved. There's a lot of pay for value. There's a lot of infrastructure that's not in these other areas that we've also talked about. And so it really will require a wholesale look at this, but we are not close to where we need to be in my mind in terms of the investment needed.
What do you think, Jackie? I mean, is there enough being spent in hospitals and elsewhere on infection prevention?
Yeah, and it's one of our favorite sayings is infection prevention is not a person, it's a program, right? So I've been very fortunate. One of the things that we built when I joined HCA is building a division infrastructure of infection prevention leaders. And thank goodness we had that runway, because that was so needed and crucial in messaging out to at scale. And so we have over 185 facilities divided up into 15 divisions, and each of the 15 divisions, thankfully, had an infection prevention leader at the helm. And that was an investment it took a business case. I had to say, and to really try to get the message across of the need of a system program. And so thankfully, that was in place. And I agree. I think there's so much more that we have to go in terms of developing that program and infrastructure.
I've got a couple of, thank you. I've got a couple of questions coming in, which we're getting close to the end of our thing. So we'll have to answer very quickly. But one is the how is intrinsically linked to the what and the why. Whose job is it to recommend infection control technologies that actually work and to call out those that don't? Individual hospital operations or a higher authority? Jackie, I'm going to give that one to you.
Sure. I think it's really important that we are responsible when we assess and evaluate products. Okay. And we need to have the entire context of a product. Many times a product can be layered on top of basic infection prevention practices. And I always say, well, how strong are your basic infection prevention practices before we layer that product on top of it? Many times a product will work, but we don't know if it was that foundation IP practice that helped to get to that outcome, or because there's extra eyes and extra focus on it, or it was actually that new technology. And again, technology and products, absolutely, they have their place. And I'm a big proponent of endorsing products when I feel that they absolutely work. But we need to make sure that we are responsible in that evaluation.
Is that any, you guys want to weigh in on that real quick or not? Should we move on?
I think move on, just get based on time, unless Mike's got something.
The last question we have here is, as healthcare providers, what are our responsibilities with patients in regards to education in the IP field? Sepsis, disease transmission, antibiotic awareness. It's difficult when patients look for this information online or social media. Michael, what do you think?
The reality here is that as clinicians, there is precious little time to actually educate our friends and family, our patients and their families. It would be wonderful if clinicians could be the ones delivering that information, but I think we all realize that that's not realistic. I do think, getting back to Devin's original point and what Jackie was saying about investments in training, we can do a better job of teaching all the way from primary school up through professional education, the basics of infection transmission in a way that is practical and really should be part of the normal tools of a grown-up. We've kind of slacked off in that area, and that's why we see so much fear-driven acceptance of craziness online and silly things in the media. There's a need, I think, to retool our educational systems, because it's not just COVID. It's why don't you eat a raw chicken leg? Well, partly it's yucky, but also it can kill you. What is it about swimming pools that require basic maintenance so that you don't get diarrheal diseases? What is it about showers and other water systems that need to be maintained so you don't get Legionnaire's disease, right? There's all this stuff that is stuff that we encounter every single day that requires a basic sense of understanding. Why do you not want to ignore a skinned knee that looks like it's infected? Because you could die of sepsis. And getting to care right away is the right answer. So I would just say that the opportunities here for improving the base of understanding is tremendous. And that gets to that how that helps people then understand, or gets to the why that helps people understand the how and the what for a lot of different things.
Excellent. Well, as a journalist whose job it is, I guess, to educate the public, it's probably that question was probably more aimed at me. But I'm just gonna dodge it on the grounds that we're out of time. So I want to thank you guys very much for being such good sports and coming on and having this conversation. And I think we have moved the needle forward a little bit, and I wish you all the best of luck.
Great to be with you. Thank you, everybody.
Thank you, everyone.
Bye-bye.
Bye-bye.